Today I'm going to talk to you a little bit about anterior closing wedge slope-reducing osteotomies, considerations with regards to osteotomy technique and degree of slope correction. No relevant disclosures. So slope-reducing osteotomy has been well validated in the literature to decrease anterior tibial translation and thus decrease the forces seen by ACL grafts. There's highly variable techniques in which you can do these osteotomies, mainly with regards to tubercle management and where your osteotomies start. So you can do these supratubercle, above the tubercle, through the tubercle, or transtubercle, or below the tubercle, infratubercle. You can also start your osteotomy at different places on the tibia. So you can start just on the tibial tubercle, or you can start anywhere else on the tibia that you like. And there's really been not much in the literature to look at a osteotomy that is specifically intended to correct sagittal alignment and whether it potentially has some unintended consequences on coronal alignment. So the purpose of this study was twofold. Number one, we wanted to determine the impact that anterior closing wedge slope-reducing osteotomy has on coronal alignment of the knee and whether it is technique dependent. And number two, to examine this relationship between coronal alignment of the knee and factors such as degree of slope correction and other things such as tibial-tubercle position. So we looked at patients presenting to our level 1 trauma center who all had lower extremity CT scans, and we retrospectively reviewed these CT scans and included anyone that had a posterior tibial slope of greater than or equal to 12 degrees and did not have any secondary trauma to that limb. We generated 3D tibia models from these CT scans with a software called Materialized Mimics, and we made 6 different osteotomies on each tibia. We did an infratubercle, a transtubercle, and a supratubercle, and then we had 2 different start points for each one directly over the tibial tubercle and one over the mid-axis center point of the tibia itself. We corrected all slopes universally to 6 degrees to control this, and as I said, we did 6 osteotomies per tibia. Here's an example of the start points that we had for each of our osteotomies. This is the 3-dimensional model that we created in the coronal, axial, and sagittal planes. You can see our start point, supratubercle, transtubercle, and infratubercle, and then directly over the tibial tubercle, and then at that mid-axis point of the tibia itself. Overall, coronal alignment was measured using the medial proximal tibial angle before and after osteotomy. We measured the slope before and after osteotomy, and we also measured the tibial tubercle trochlear groove distance before and after osteotomy. We also subanalyzed tibias to anyone who had a correction greater than or equal to 9 degrees, so people with higher slopes that needed bigger slope corrections, and people with bigger TTTGs or more lateral tubercles to see if this would impact anything. This is just an example of an infratubercle osteotomy that was performed before on the left side of the screen, after on the right side of the screen. You can clearly see the change in the slope. Overall, we included 11 tibias from 9 individuals. The average slope was 14.5 degrees. The average TTTG was 14.8 millimeters. All osteotomies increased or created additional varus. The 2 that were statistically significant were the infratubercle and the transtubercle osteotomies, where the start point was directly over the AP mid-sagittal or mid-coronal axis of the tibia. Each osteotomy also had a positive correlation with degree of slope change, as well with the amount of coronal change that we saw. So you can see here on this graph, it was especially apparent in the AP, the supratubercle, infratubercle, and transtubercle, the AP start points. All of them had a significant correlation where as we're increasing the amount of slope we're correcting, it resulted in an increased change in the medial proximal tibial angle. So in conclusion, isolated anterior closing wedge slope-reducing osteotomy does and can impact coronal knee alignment on the knee, especially in transtubercle and infratubercle osteotomies when you do not start the osteotomy over the tibial tubercle. We saw increases as high as 5 degrees, which obviously we couldn't look at whether this was clinically relevant, but would imagine that anyone, especially if they're starting with some baseline varus, a 5-degree change in coronal alignment would impact the overall balancing of their knee. So it's really important when considering doing this procedure. Number one, scrutinizing the patient's preoperative coronal alignment, considering the amount of slope you're going to have to correct, and then based upon these factors, deciding which technique you want to use. Thank you. I'd like to give acknowledgments to my research mentor here, Dr. Alfred Mansour, and everyone else who is involved in the study. Thank you.